Potpourri session, and this is the last session of this conference in this hall. And first, I would like to invite first the chairperson and panelists. I think Dr. Prasant is not here, Dr. Anand Devi is not here, Dr. Sudipto is also not here. So I like to invite Naginder sir to take seat first as chairperson. And Dr. Silpi is here. So I think only 3 presenters are there in this session. So first I would request to start from Dr. Naginder sir with his presentation, perfecting Tori IOL implantation technique. So sir needs no introduction. Sir is doing high volume surgery and quality surgery in different type of cataract. Yeah. Okay. Please come. Please come.
Thanks, Dr. Amit, and at least we could find some audience here in the last session of this, and it is very enthusiastic for me also. So my topic is perfecting toric IOL implantation technique. I have no financial disclosure. As you know that modern cataract surgery is more of a refractive surgery, and myopia and hypermetria can be corrected using appropriate spherical power of the lens, but there is a 20% of patients who undergo cataract surgery have more than 1.25 diopter of corneal astigmatism, which is visually significant after the surgery, and they are very unsatisfied if you don't correct them. And the best way to correct is by implantation of the toric IOL. So how to achieve the perfect result? Technology and surgeon technique and combination of both surgeon and technology achieves the best results and best outcome. Now coming to the what are the prerequisites for the toric IOL, and good central capsule axis is very important in these cases to remain the lens into center for the longer duration, longer times. Precise keratometry is again very important. If you don't do keratometry properly, then you will have the suboptimal results. Accurate biometry is again important. If you have done the beautiful implanted the toric IOL, but your biometry is not good, so again it is a source of the dissatisfaction to the patient. And you must know what is your surgically induced astigmatism, because while making calculation for the making calculation, you must incorporate your surgically induced astigmatism to have a better outcome. There have been a certain IOL make and material which have effect on rotational stability of the IOL. So we'll coming on the later. Material of IOL is important, and marking axis is very important. You have to mark the axis perfectly, and you can use various methods for marking, and you can have a markerless viewing system, visual system. Size is important because if you have a perfect axis, and it should be not more than 5.5, maybe slightly smaller axis is preferable in these cases, and it should be central. If you make a small axis, you will end up with this kind of the picture, and that will lead to decentration of the IOL, and you have to do additional activity. This is the perfect axis up to the 5 mm, 5.25, 5.5, it is perfect, and the IOL should be covered at most 0.5 mm on the optic of the IOL. So it keeps in the bag all the time. You can, for the axis, you can use your simple corneal marker with the metal marker on the cornea. You can just touch it, or you can use this markerless Callisto system, which I have been using. So guide for the perfect axis and sizing of the axis. So you can use this better. So this is very important step while doing a toric IOL implantation. Now, accurate keratometry, how to obtain accurate keratometry? You can have manual, automated, and coordinate topography also. most of the surgeon use the amount of astigmatism with the one machine like Master, and for the axis they use the corneal topography. And if you are not obtaining the good result with the keratometer, then you can use corneal topography for the obtaining the accurate keratometry. K reading for all three, so high repeatability and are comparable. Manual keratometer should be calibrated regularly. It should keep in mind that it should not be recalibrated, and corneal topography is required in cases of unusual reading and poor quality of mice. Precaution must be taken that reading must be quick to avoid corneal drying, because most of the machine uses the tear film for the obtaining the keratometry values. Don't rub the cornea beforehand. Centration must be proper to obtain the best result. Accurate biometry, I used best immersion technique gives the best results, and optical biometry both are equally comparable. But A scan using have lots of sometimes having a problem in accuracy of the biometry. Depends upon the surgeons and the person who have been doing A scan. So far as for calculation formula is concerned, best is Barrett suits, which I have been doing since last many years, and you must know how to calculate the surgically induced astigmatism. As you know that every incision changes the cornea, closer to the center and larger the incision, more effect on the corneal curvature. Other factors also affect like corneal age and suture. In addition, there is a variability from the patient to patient, and overall effect can be summed up into vector analysis later on. To obtain a surgical induced astigmatism, there is a calculator available. Fill it for 20 to 30 cases minimum, and you just click on, and that gives you the precise about the axis and the incision. So this is the data input. You can in the calculator online available. You can enter the data, patient data, keratometry, spherical power, surgical astigmatism, and incision location, and by this is the output screen. This guide where to place the incision and where to place the axis of the IL. Rotational stability is very important factor. It depends upon the surgical technique. If you are having good axis and all, then there is a chances of having rotation is less. Apart from the other factors, oil material and design is important, because material like silicone oils have less stable than the acrylic material, and the open loop haptic is slightly less stable than the closed loop like plate haptics are. So the design is important. Placement of oil in the bag is important, otherwise you will have different results. Axial length is important. If you are having a high axial length, there is a big bag and also there is a chances of rotational problem. Orientation of oil in the bag is also important. Like suppose if you are, whether we are implanting which axis, like 180 degree or 90 degree or any other vertical or horizontal. If you are implanting on the horizontal, there is a less chances of rotational than the comparable to the vertical orientation of the aisle. And if different aisle behave differently, some aisle tend to rotate anti-clockwise, some aisle tend to rotate clockwise from the vertical orientation. So this you have to take consideration into the. And now coming to the intraocular pressure, you keep your intraocular pressure at optimum level. If you overinflate, then there is a capsular bag enhancement. Removal of viscoelastics is very important, and you must remove from the posterior aspect after the implantation, after the placement of the IL, or you can use hydroimplantation technique like this here after implantation. So you don't have to remove the viscoelastics from the bag, and just you can align with the axis marker projected from the microscope. Material is important, as I previously told. Rotational stability I have already told. Marking, you can use bubble marker, which I used, and marking should be perfect, and it should not be fuzzed out margin. Gravity mark is also available, so I have not used till now. Reference marking should be done to mark the 180 degree and 90, and for before the marking, the dry conductor should be dry. Enhance the marking at 309 crore position. apply marked with twisting action, and it lasts throughout the surgery. And this is the marking, just a couple of minutes. If you mark this type of, this is a manual marker. First you have to mark the perioperative axis marker, then on the table you have to mark the axis of implantation. But the marking should be precise, otherwise you will have a problem in aligning the axis. Or you can use markerless, which I have already shown there, previous slides. Rotational stability, already talked about it, and intraocular pressure, like post-operative hypertony plays important role in misalignment or rotation of the toric aisle, and it occurs within first hour of the surgery. So always check the target axis after 1 hour, and corrected measures should be done. Too wound tight and too leaky wound lead to increased IOP and the bag inflation and collapse of the capsular bag leading to the rotation. So try to remain within the physiologic aisle. Residual astigmatism, important point. For every degree of rotation, there is a 3.3% loss of correction, and 30-degree rotation almost equal to a spherical aisle. So it should not be, if it is more than 30 degree, you are going to induce the astigmatism in the opposite direction. Rotate the aisle if residual astigmatism is 0.5 diopter or less than 10 degree, no intervention. If it is not required. If it is less than 10 degree, if it is more than 10 degree, simply mark the target axis on the slit lamp and rotate, or use online calculator. You enter your data, current manifest refraction, astigmatic magnitude, and IOP axis, and then calculate where to put, where to rotate, in which side. So, in conclusion, center axis, a smooth axis, and thorough removal viscoelastic from the interior capsule and the surface of the aisle. Preferably 2 incisions, side port and main incision, to prevent the collapse. After alignment, prevent collapse of the anterior chamber. Always 2-3 degrees short of the desired axis, so you can rotate later on. So meticulous wound construction, well-centered, smooth, adequate size capsulotomy. Positioning of the aisle on the target axis should be there, and aim for tightly sealed wounded, not high IOP. Thank you for patient learning. I take the liberty because the speakers are less. Thank you.
Thank you, sir, for excellent presentation, and you have rightly pointed out the importance of marking and removal of residual viscoelastic. Residual viscoelastic is one of the important factor for rotation, especially in early post-operative period. So
Yeah.
it should be removed. Another thing I want to emphasize that even if surgery is done in topical anesthesia, for first 1 hour or 2 hour it should be patched, because most of the rotation occurs in early within 1 hour or 2 hours, so it should be patched.
Yeah.
Thank you, sir.
Rightly pointed out, Dr. Thank you.
Due to eye movement, basically there is chances of rotation. So, yeah.
And residual viscoelastics behind the lens may lead to also eye rotation. There is some tendency to rotate. There are various factors which I have described, that high IOP, increased bag, axial length is more than chances. So better to check after 1 hour first of the time. So
after implanting the toric lens, do you usually press it against the posterior capsule to prevent PCO?
no, I don't do like that,
Okay.
ma'am. So
And any have you seen any posterior capsule opacification after toric implantation?
till now I am yet to see.
Yet
That
to see.
I don't know why it is not occurring there. So till now I don't have
It depends
any
on IL
experience.
factors also.
IL
Yeah, because most of the time I use I only use the one brand of oil.
Right.
So I don't believe other brands of oil they gain the same result. So, and itself this material is very known for
Less
not
PCO.
to quote unofficially that
Yeah, yeah.
Alcon I use the most of the time.
Thank you, thank you.
Thank you.
Thank you, sir. Right. Now I invite Dr. Abhishek Ranjan with his presentation. Again, he is a dynamic cornea specialist, and recently he is associated with Brightwell Hospital. Brightside.
So very good afternoon to all of you. I am talking about management approach to a non-healing corneal ulcer. I have no financial interest. So corneal ulcer is defined as loss of surface corneal epithelium along with infiltration into the surrounding and underlying layers. And non-healing or recalcitrant corneal ulcer refers to a corneal ulcer which does not respond to the conventional treatment. Response of a corneal ulcer to a treatment is indicated by a decrease in size of epithelial defect or infiltrates. The time frame for resolution differs for various etiologies of a corneal ulcer. Like in case of bacterial or viral corneal ulcer, after starting the treatment, even after 48 hours of initiation of specific antimicrobial therapy, if the ulcer is not resolving, there is no sign of improvement, then we label it as a non-resolving. And in case of fungal corneal ulcer, this time period extends up to the 5 to 6 days. Initially, even if no further progression in ulcer dimension itself highlights responsiveness of treatment to the ulcer. Any increase in dimension, non-localization of margin of the ulcer, fuzzy ill-defined borders, increase in slough are indicators for non-responsive ulcer in the treatment. When patient is followed on daily basis, worsening of the above parameters in 8 to 72 hours indicate ulcer is not responding to the treatment and need for revised diagnosis or revised medications. So there are various causes, like most important cause is incomplete treatment or non-compliance of the patient. Other causes are epitheliotoxic drugs, inaccurate diagnosis, drug-resistant microorganisms, atypical microorganisms, advanced severe corneal ulcers, ulcer with impending perforation or already perforated ulcers, retained foreign body, posterior segment involvement with endophthalmitis, and immunocompromised state. Other systemic causes like diabetes mellitus are also there. Some adnexal abnormalities like entropion, entropion-otrichiasis, leg of thalamus, dacrocystitis, any coexisting thyroid eye disease, and mechanical trauma to the cornea in the form of papillary follicles in upper lid in papillary conjunctiva. So the ulcer usually presents with acute red eye with pain, photophobia, and vision loss. There may be history of trauma with vegetative material or febrile viral keratitis. There are nature of pain also indicates the diagnosis of the organism. Like in bacterial keratitis, there is significant pain. In fungal keratitis, there is no severe pain. In acanthiva keratitis, there is severe pain owing to the radial keratoneuritis, which is usually out of proportion to the size and extent of the ulcer. In herpetic dendritic ulcer, there is minimal pain. Corneal trauma by vegetative material may indicate towards the mycotic ulcer. Prolonged contact lens wear, especially overnight or extended wear soft contact lens, may indicate towards pseudomonas species. Exposure to the dirty swimming pool water or pond water and contaminated contact lens solution may indicate towards the acanthamoeba keratitis. If there is dacrocystitis, then there may be chances of pseudomonas keratitis there. So medication prescribed earlier for the ulcer needs evaluation. Like most of the cases who presented in this region are taking topical corticosteroid, which worsen a case of probable mycotic keratitis rapidly. NSAIDs worsens the corneal ulcer and causes corneal melts. So we have to check all the medications which patients are taking priorly. History of any previous ocular surgery include cataract and refractive surgery should be taken off. In visual acuity should be checked. In central or large corneal ulcer, significant impairment of visual acuity may be there. And adnexal abnormalities must be checked for any eyelid malpositions, any adnexal abnormalities, other any conjunctivitis. In coming to the cornea, examination of cornea proper, first we have to see the location. If there is isolated peripheral ulcer, then there may be chances of herpes simplex virus or mycobacterial tuberculosis. If dry looking ulcer with feathery margin and satellite lesion, there may be chances of mycotic keratitis. Dendritic ulcers are seen in herpes simplex keratitis. Ring ulcers are seen in acanthamoeba keratitis, and bacterial ulcer are usually wet looking with punched out appearance. Margin of ulcer, in case of peripheral ulcerative keratitis, overhanging edges are there, and that may be because of Murren's ulcer. The most important indicator of response to the ulcer is size of both the epithelial defect and surrounding infiltrates. The size, density, and depth of infiltrate is recorded in detail in each and every visit, and reference to be taken in follow-up to evaluate response of that corneal ulcer to the treatment. Corneal sensation must be checked, to particularly it is decreased in cases of viral keratitis. In anterior chamber, we have to look for hypopyon, which may be associated with any corneal ulcer. In fungal keratitis, fixed hypopyon is there that does not change position despite making the patient lie supine for at least 10 minutes. If there is posterior segment is visible, then okay, otherwise we have to do BS scan for that. Documentation of location, size, shape and visualization of corneal ulcer is very important. It becomes even more important in case of recalcitrant corneal ulcer. Colored clinical photographs may be taken, or schematic diagrams must be drawn on the paper for each and every visit. So we have to rule out any systemic diseases, especially diabetes mellitus and any other immunocompromised diseases. In ocular investigation, we look for intraocular pressure, VS scan to evaluate posterior segment. Corneal scraping should be done in case of recalcitrant keratitis. The previous treatment should be done for at least 24 hours and fresh corneal scraping should be done. If there is any conjunctival discharge or like ramal sac discharge or bandage contact lens, that is separately sent for microbiological examination. Along with culture, other microbiological investigation that need to be done includes gram staining, GIMSA staining, Gill-Nielsen staining and QH weight mount. Other specialized investigation may include confocal microscopy and serological testing, including PCR, that may also aid in diagnosis. Corneal biopsy or suture biopsy may be taken for deeper ulcers. An anterior chamber paracentesis can be done for microbiological investigation in case of hypopyon corneal ulcer. After that, we have to start with the empirical therapy like broad spectrum antibiotics such as fortified cefazolin 5% and fortified tobramycin or ciprofloxacin. Cycloplegic is used for cyclitic pain relief, and systemic antibiotics should be given in large ulcers with impending perforation or scleral involvement, and in case of posterior segment involvement. After giving those empirical therapy, once we get the culture report, then we have to start with the definitive therapy according to the culture reports for organisms, whatever organisms are there. So in case of fungal keratitis, if topical treatment is not working, then we can go for intrastomal voriconazole injection as a targeted drug delivery system. Intrastomal voriconazole in a dose of 50 microgram per 0.1 ml administered using 1 ml tuberculin syringe and 26 gauge needle. Intracameral and intrastomal voriconazole can be given if there is hypopyon is there. Amniotic membrane graft is effective alternative for treating persistent neurotrophic ulcer and non-traumatic corneal perforations and descemetocele. Tarsorrhaphy should be planned early in cases of neurotrophic cases. In non-healing epithelial defects, tarsorrhaphy is reported to have 80% to 100% success rate for complete healing. It should be performed sooner rather than later when persistent epithelial defect do not respond to the medical therapy. Collagen cross-linking is an effective procedure in treating non-resolving microbial keratitis with superficial stromal involvement. It provides early symptomatic relief to the patient by decreasing corneal sensation and hence reducing the pain. Therapeutic keratoplasty has a role in management of severe and refractive keratitis with high success rate in restoring anatomical integrity. It is indicated when their infection is clearly not responding to the conservative medical treatment, if there is threatened perforation and likelihood of spread to the limbus or sclera, endophthalmitis where it may need to be combined with vitrectomy, and in cases of threatened panophthalmitis. So these are few examples of the cases which are presented in as a non-resolving corneal ulcer, and after therapeutic keratoplasty they have done well. So to conclude, recalcitrant microbial keratitis is a challenge to every ophthalmologist. Its management involves a step-by-step approach. Timely diagnosis and intervention may save the ulcer from perforation. Timely referral is also important. Newer modalities such as collagen cross-linking, intrastomal and intracameral drug injections, and other methods of targeted drug delivery system may be tried. If the infection is clearly not responding to the conservative medical treatment, therapeutic keratoplasty should be considered. Thank you.
Thank you, Dr. Abhishek. Excellent presentation covering all the aspects of non-healing corneal ulcer. And we generally overlook the adnexal finding, especially entropion in a foreign body, that should be thoroughly examined to rule out this factor may aggravate non-healing corneal ulcer, especially in viral cases when we pump so much of antibiotic, then basically you have to minimize the preservative so that epithelial healing should be promoted with the amniotic membrane grafting. And finally, tarsorrhaphy. In non-healing corneal ulcer, one should go for tarsorrhaphy if nothing is working. Any more comment?
Regarding the collagen cross-linking, how is it actually done?
It is actually, it is reported, but it is done like in normal keratoconus cases. You just put the riboflavin eye drop and that.
So is it available here in India?
Collagen cross-linking machine is there, like
Machines.
in keratoconus. The same machine is, with the same machine you can do in
Okay.
microbial keratitis also.
Okay. Thank you.
Excellent presentation. I will say just one word. Intrastromal, what is your experience with intrastromal, interlesional, antifungal and all? Just to
Sir,
know
for
about
fungal keratitis, if the infiltrate is in deeper corneal, like in mid-stromal or posterior stromal layers, it works very good. Actually, it works if given properly.
basically, if it is a posterior stromal, I think.
Mid to posterior
Mid and
stromal.
posterior.
Mid and posterior stromal, if where the like antifungal penetration is very poor, you just put with that 30 gauge needle or maybe 26 gauge needle. It works. It actually works if given properly.
And
But
how
one
much-
thing you have to take care that cornea should not be thin. That is the most important thing, because if the cornea is thin and if you put that thing, it will perforate.
And how much quantity you just inject because it is tight?
So I just take about 0.2 to 0.3 ml in 1 ml syringe, and just in ring, just put multiple sides and just breeze it around all the infiltrate. And one thing is also taken care is it should not be in the infiltrate. It should be at the junction of the healthy cornea and the infiltrate. You should not put in the infiltrate directly.
Nice take home message.
Thank you.
Thank you.
I think no more presenter is here.
Yeah.
So we should conclude this
Conclude the
session.
session. Okay.
Thank you all the presenter and chairman and above all the delegates.
Audience, delegates के लिए भी चाहिए time.
So I would like to invite even delegates also for the photograph.
Photograph. आ जाइए, आ जाइए.
इधर लीजिए जल्दी से, यहाँ लीजिए ना, एक ठो पहले मेरा लीजिए।